Hello and welcome to today's edition of Patcast. Today is Friday, November 3rd, 2020. I'm Rifat Manan in Philadelphia, and I am remotely joined, as always, by my very good friend Emilio Madrigal, who is currently in Boston. Today, we are very delighted to welcome back Dr. Margie Morgan once again, who is microbiologist and from Cedars Sinai Medical Center at Los Angeles, and she would be delivering the 5th lecture in the microbiology lecture series that she has been doing now. And the title of today's talk is Mycobacteriology. As always, please feel free to post your questions and comments on YouTube and Facebook chat windows, and Dr. Morgan will be more than happy to answer them towards the end of the session. And thank you so much, Dr. Morgan, for joining us today. Over to you now.
Thank you very much. Welcome to this microbiology session on mycobacteriology. I have to say it's a very broad topic, so I only have time to do an overview, but I hope you'll find it helpful. So let's get started on mycobacteriology. What are mycobacteria? Well, they're acid-fast bacilli, or we call them AFB. They have a thick outer cell wall made of complex mycolic acids, also known as mycolates, and free lipids, which contribute to the hardiness of the genus. Acid-fast, they're called acid-fast because once they're stained, the AFB will resist decolorization with acid alcohol. You need to make sure that you know the difference between a true AFB stain and a so-called modified or partial acid-fast stain. A true AFB stain uses HCl to decolorize, and mycobacteria will stain with an AFB stain, but organisms such as nocardia will not. A partial acid-fast stain uses H2SO4 to decolorize. The mycobacteria and the nocardia will both stain positive on PAF. If you look at the upper right-hand side, you can see that AFB stain very poorly with gram stain. They stain as beaded gram-positive rods, but it's so beaded it almost looks like it's debris. These organisms are aerobic, they do not produce spores, and they rarely branch. Identification of the mycobacteria has certainly changed over the years. For decades, identification started by determining the ability of a mycobacteria species to form a yellow carotenoid pigment in the light or dark. This was then followed by a flowchart of the proper biochemical reactions, the growth rate, and optimal temperature for growth. This has become obsolete over the years due to the taxonomic changes in this genus. Also, with expanding taxonomy, biochemical reactions were unable to identify the newly recognized species, so for a time we used high-performance liquid chromatography. But this has now also become obsolete. Current methods are genetic probe testing, MALDI-TOF, and sequencing for genetic sequence information. Mycobacteria taxonomy, currently there's many more species than a few decades ago, and they're divided into two groups. Group 1, known as the TB complex organisms, which include Mycobacterium tuberculosis, M. bovis, M. africanum, and a few rare species of mycobacteria. Group 2 are the mycobacteria other than TB complex, known as MOT, also known as the non-tuberculous mycobacteria. The slowly growing non-tuberculous mycobacteria that are capable of causing disease are listed on the top part of this slide. That is the first group. The second group are rapid growing mycobacteria that grow in less than 7 days. And then the third group is Mycobacterium leprae. During this lecture, we will go through these groups as well as the TB complex to talk about the most important organisms or species within those groups. These are the mycobacteria that rarely, if ever, cause disease. If so, only in the severely immune compromised. And one of the most common ones is the slow-growing non-tuberculous mycobacteria, Mycobacterium gordoni. And we will talk about it a bit later. So let's first start with identification of MOT, or the non-tuberculous mycobacteria, and let's look at the older way that used to be used, because sometimes these older ways might be relevant. was based on what was called the Runyon system. And this was a classification system that was only for the non-tuberculous mycobacteria. It does not include MTB complex. The Runyon system is based on a yellow carotenoid pigment that can be produced when it is exposed to an incandescent light bulb. Also, you need to look at the growth rate of the mycobacteria. There are 4 Runyon groups: photochromogen, scotochromogen, non-photochromogen, and rapid grower. And we will briefly review these. First off, what is this light test that I'm talking about? Well, it determines if a mycobacteria can produce a yellow carotenoid pigment after being exposed to 8 hours of an incandescent light. After the light exposure, you then again incubate the cultures for 24 hours, and then you observe what they look like after being in the dark and being in the light. Group 1, photochromogens, you can see that the one that was exposed to light produced that yellow carotenoid pigment, and it turns yellow after light exposure. Group 2 is scotochromogen. The yellow pigment is present in both light and dark situation. And then group 3 is the non-photochromogen. No matter whether it's exposed to light or not, there is no pigment produced. So this used to be the first grouping in the of our identification of the mycobacteria. Once we knew that, say, it was a photochromogen, then we would have specific biochemical tests we would then use for that organism to get to the species level. Breaking it down a little bit further, we can see different organisms that appear in different groups. The photochromogens, the primary one being M. consacii, but I do want to bring note to some of the unusual things that we used to use the light test for, such as M. schulgii. It's a rather uncommon organism and is a photochromogen when incubated at 25 degrees. But if you take this same organism and you put it at 37 degrees, it's a scotochromogen. And so these are the old kind of use of the light test plus biochemicals that we used to have to go through to identify the mycobacteria. Group 2, the scotochromogens, include some of the less common strains, such as M. gordoni, M. xenopi, and M. schulgii. Group 3, non-photochromogens, includes the very important species of M. avium intracellulare complex. And then group 4 are the rapid growers. They will grow in less than or equal to 7 days. When we work in the AFB laboratory, we have to be very aware of safety. You use level 3 biosafety precautions in an AFB laboratory, particularly ones that process, identify, and perform susceptibility testing, because during those procedures, you will have a large number of organisms underneath your biosafety cabinet. You must use a level 2 HEPA filtered biosafety cabinet with return air vented to the outside. And you can see the arrow pointing in the picture. There's actually a stope or it feeds up through the ceiling and is vented to the outside. You must have these biosafety cabinets certified at least yearly to ensure that you have proper operations and your lab is safe. The laboratory requires negative airflow. You need an ante-room for entry for your safe gear donning and doffing. Contiguous autoclave. N95 respirator masks must be worn with a yearly mask fit test. Or you need to wear a PAPR, which is a powered air purifying respirator mask. So you have a double whammy of protection. You have the level 2 HEPA filtered biosafety cabinet, and then you have respirator masks to protect you as well. And of course, with all of this, you wear gloves, disposable surgical gowns for all of your for all your culture work. Specimen collection is very important for doing AFB work. Historically, we've always said to collect 3 early morning collections of sputum, and that was the primary way that we would try to diagnose a respiratory case of tuberculosis. Over time, this became a very long, drawn-out process. It could take 3 or 4 days or longer to get these 3 early morning specimens, and that could delay releasing a patient from isolation or from discharge from the hospital. So now, per regulation, it is allowed to do 1 early morning collection of sputum plus 2 collected at least 8 hours apart. There's a variety of different kinds of specimens that can be collected and sent for AFB culture, including respiratory specimens, tissues or lesions, sterile body fluids, urines, of which you need to do 3 to 5 specimens to really get a sensitive collection. We can even do stool, mostly for M. avium complex. In children, sometimes it can be very difficult to collect proper respiratory specimens, so they will collect gastrics on children. You need to remember that if a gastric is sent to the laboratory, you need to neutralize the gastric to a pH of 7 for the AFB to survive. Of course, we can also do blood and bone marrow cultures if you're suspecting disseminated disease. There's automated systems and specific bottles for specimen collection to put into these automated systems for detection. AFB specimen processing for potentially contaminated specimens. The process I'm going to go through is mostly for what you suspect to be contaminated specimens, particularly sputum bronch lavage. You would first use a conical Falcon tube. You need to use a very thick tube for your processing because you're going to be centrifuging at high speeds. You will have 5 mils of specimen added to that tube. You will then decontaminate and liquefy the specimen for 15 minutes using 4% NaOH, which will increase the pH to 9, and that will kill off any bacteria that might be in the specimen. You also use N-acetyl L-cysteine to liquefy the mucus in the specimen. After you set that for 15 minutes in that solution, you then neutralize with phosphate buffer to a pH of 7. After that, you need to centrifuge for 30 minutes. You need to use safety cups with tight lids to make sure that your centrifuge is safe, and you will centrifuge at 3,000 times G to pellet the AFB. You pour off the supernatant, and you use the pellet to make your AFB staining. Then you dilute the pellet with a bit more saline to make your cultures. You incubate your culture media at 37 degrees or 5 to 10% CO2 for 6 to 8 weeks. If you're in your hospital, you have a lot of cystic fibrosis patients, you have to be aware of those specimens collected from those patients and use a separate decontamination process under these special circumstances. For cystic fibrosis patients, you want to decontaminate the specimens with oxalic acid. This will eliminate the very mucoid strains of Pseudomonas aeruginosa that will not be killed by the regular 4% NaOH. You should not make the decision to use oxalic acid, however, on all of your specimens because this could decrease your AFB yield. Both 4% NaOH or oxalic acid will kill AFB if left on the specimen greater than 15 minutes. So this decontamination process is certainly a timed procedure. The specimen centrifugation, as I said, is very important and should be at 3,000 times G. The speed is important because the AFB are lipid-laden organisms and will float if they're not centrifuged rapidly enough. And if you then, you won't sufficiently pellet the AFB. The sensitivity of your AFB stain and of your cultures is very dependent upon centrifuging at the proper high speed. Now, what kind of media do we use for AFB cultures? There's 2 types of manual plating media that we use, Middlebrook and Lowenstein-Jensen. Middlebrook is pictured there as a synthetic media with optimal chemical ingredients to grow the Mycobacteria. It's a clear-colored, both solid and liquid media. It can be used for culture and susceptibility testing, and it can be autoclaved to sterilize. Lowenstein-Jensen was created back in the early 1900s. It's a very basic media with egg, with glycerol and flour. It's a solid agar only. The green color, which is a very unique kind of shade of green, is due to malachite green. It's only a culture media, and you sterilize by a drying process called inspisation. Cultures, if you're doing manual plating methods, are incubated at 37 degrees, 5 to 10% CO2 for a total of 8 weeks. Automated detection of AFB came in the late 90s and really revolutionized and sped up the detection of AFB. The most common instrument used is the BD Bactec Midget 960, and it is just an automated instrument for the sole purpose of isolation of AFB. As you can see in the picture there, it uses Middlebrook 12B liquid media with a growth indicator in the culture tube. The way this works is as the AFB grow in the 12B media, the AFB will respire CO2, and then the amount of oxygen is decreased over time. As the lower levels of oxygen move forward, it causes fluorescence of the indicator at the bottom of the tube. This will indicate high CO2 from the presence of the respiration of a growing organism and the lowering of the O2. This will be triggered in the instrument, and you will know you have a positive culture. When you use automation for detection of AFB, you only need to incubate for 6 weeks. Also, generally, the growth of your AFB is sped up using this automated detection, so you are able to detect organisms much faster. Another advantage of having an automated system is there is a simple test for the identification of the TB complex organisms. It's known as the NAP test. The NAP is a chemical with a very long name, which I won't even try to say this morning. But the TB complex will not grow in a tube that contains NAP. But the non-tuberculous mycobacteria will grow in this NAP chemical. So this can be a very easy to perform test for a laboratory not capable of doing MALDI-TOF or sequencing for the identification of the mycobacteria. Acid-fast staining for AFB. First, we'll talk about the carbofuchsin stains. When you use carbofuchsin, it is your red-colored primary stain for staining the AFB, as shown in the picture on the right. The blue counter stain is potassium permanganate. Historically, there's been 2 methods of using carbofuchsin stains. The Ziehl-Neelsen, which historically we used, which used heat to drive stain into the lipid-laden AFB. For the last several decades, we've used a Kenyon. It's a cold stain. It is the high percentage of phenol in the stain is what drives the stain into the AFB. When you're using a carbofuchsin-based stain, it can be rather a dull-looking stain, so you need to read numerous microscopic fields on a 100x oil objective, and you need the regulatory demands are to read a slide for 5 minutes using this method. Fluorochrome staining. This came in about 2.5, 3 decades ago, and the primary one used is aramine rhodamine. And of course, this is a fluorescent stain. The AFB rods will stain fluorescent yellow with a black background. You can read these slides at 25x or 40x for a total of around 2 minutes. You view numerous fields during that time using a fluorescence microscope. The nonspecific fluorochrome binds to the mycolic acids present in the Mycobacteria cell wall. This stain is considered to be more sensitive than Ziehl-Neelsen or Kenyon for concentrated patient specimen slide examination. It's not because it necessarily picks up more organism, they're just easier to see. We also can pay attention to the morphology of the organism when looking at AFB stains. Not all of them have a unique morphology, but the 2 main ones that we see and the main ones that we look for morphology would be Mycobacterium avium complex and TB. On the left-hand side is what Mycobacterium avium complex looks like on a slide. The organisms are short rods. There's no cording. They just appear in random groups. They don't appear to be stuck together. They're just grouping. On the right-hand side is what Mycobacterium tuberculosis will look like in a patient smear. The organisms are long rods, and they appear as if they are sticking together. And this is due to what's called cord factor. The bottom right-hand picture is what a broth culture of Mycobacterium tuberculosis will look like when stained with a carbofuran-based stain. You can see that you're virtually seeing ropes of organisms because they're so sticking together so well. And this is once again due to cord factor of MTB. Direct detection of TB complex from respiratory specimens using molecular amplification has become very important over the last decade. It is a way to rapidly find patients who have MTB infection. There's an FDA-cleared assay that can detect TB complex organism DNA in sputum. It is the Cepheid Expert TB ribampin assay, or the RT-PCR. It can detect TB complex organism gene sequence and ribampin resistance gene. So you not only can detect the presence of the organism in the patient's respiratory specimen, but also if it's possibly resistant to ribampin. These assays are quite sensitive. If you're dealing with a patient that has a large number of organisms and has a positive AFB smear, this assay can detect 99% of these. And it will detect 75% of the patients that have smear negative but have the organism within their respiratory specimen. It's a very good test of diagnosis, but we must remember that you never do these tests to see if a patient is cured. You can have residual RNA and DNA for up to 6 months in these specimens. And this is after initial start of therapy, and good therapy, you can still shed organism. Also, you must remember that even though this test is very sensitive and specific for the detection of Mycobacterium tuberculosis complex in respiratory specimens, the gold standard that must always be performed is AFB culture and sensitivity testing. For decades, we've used the Purified Protein Derivative, or PPD, Mantoux test or TB skin test to detect latent or current TB complex exposure. We must remember when using a PPD, you can have false positive reactions in patients that have been previously immunized with BCG. BCG, of course, is a Bacillus of Calmette-Guerin, which is an M. bovis-related strain. You can also have false negative reactions, usually about 25%. Usually these patients will have low T cell numbers or T cell reactivity. You can also have technical problems with the administration of a PPD. Also, subjective test interpretation, which can lead to either false negative or false positive reactions. It measures delayed hypersensitivity, or the T cell response, to the TB complex antigens. You must remember this test, of course, is not specific for TB. It also detects TB complex, which includes M. bovis, which includes BCG. The interpretation of this test, you should measure in millimeters the area of induration, not just redness, but the actual induration at the injection site. Greater than 15 millimeters is thought to be a positive reaction, but you want to know if the patient has received BCG or not. Greater than 10 is positive in the immune suppressed, or if you're doing an outbreak investigation for people that might have been just exposed. We used PPD for decades until there seemed to be some problems in the production of the protein derivative itself, and there was a low supply, which gave an open door to some of the cell mitogen assays to become far more popular. For more than a decade, we've been using these interferon gamma release assays to screen for the latent and current infection with TB. The primary test that has been used recently has been the QuantiFERON TB Gold Plus. This detects both CD4 and CD8 T cells in patients' whole blood samples stimulated with TB-specific antigens. If a patient has active or latent exposure to TB, the stimulated T cells will produce gamma interferon. We then use an automated enzyme immunoassay, which measures gamma interferon produced. It gives you a quantitative endpoint that determines either a positive or negative reaction. Unfortunately, sometimes, however, you might get an indeterminate reaction in a quantiferon TB Gold Plus. This will most likely occur if T cells are absent or inactive due to medications. It can also happen if the tubes are not shaken at the time of blood collection, because it is an in-tube assay that starts at the time of blood collection. A great advantage of this assay is there's no false positive reactions from immunization with BCG. The sensitivity is thought to be equal or greater than 80%, but it does not replace culture for disease diagnosis. You must always do a culture with sensitivity in a patient suspected of having TB. Sensitivity is similar to PPD, but of course it has improved specificity. Now let's talk about some of the most common organisms within the genus Mycobacterium. Let's start with tuberculosis. This organism grows well at the 37 degrees that our incubators are set at, and usually grows in about 12 to 25 days. If we use an automated system for detection, we might be able to speed that up a bit. Look at the colony. It's really quite unique. It's buff-colored, and it looks like a head of cauliflower sitting on an agar plate. If we're using manual tests for identification, this is a bit old school, but they are classic. We would start with a niacin accumulation test, which would be positive for TB. Niacin is produced from the growth of the TB organism on egg-containing media, such as Lowenstein-Jensen. And then we would do a reaction, a biochemical reaction, to determine the presence of niacin. Also, TB has a nitrate reduction test that is positive. So niacin and nitrate positive were the old manual tests that we used to use. Currently, we've moved forward and we're using molecular DNA RNA hybridization to identify TB complex. And for specific TB identification, we can use MALDI-TOF mass spec and 16S RNA sequencing. When doing direct patient slides from respiratory specimens or other specimens looking for TB, we can observe the morphology of the organism, which will be long AFB that stick together. The TB produce cord factor. This is high lipid content in the cell wall that allows the rods to stick together in direct patient smears and to develop long ropes when grown in broth media. This feature is unique to M. tuberculosis. Susceptibility testing of TB. There have been various methods used over the decades, but the most commonly used one now are liquid 7H12 medium tubes that contain anti-TB antibiotic solutions. You can purchase these tubes, and then they are put into the automated Bactec midget system. They test for your primary TB drugs. There's 5 drugs that you think of in the primary therapy of Mycobacterium tuberculosis: INH, pyrazinamide, rivampin, ethambutol, and streptomycin. If you do testing on the primary drugs, you need to do the second-line drug testing. This is normally sent to a public health department or to an outreach testing facility. Normally, a clinical microbiology laboratory will not be testing second-line TB drugs. The second-line drugs include the fluoroquinolones, kanamycin, amikacin, and capreomycin. If a patient remains culture positive after 4 months of what is considered to be ongoing therapy, you need to really question if something was missed in the initial testing of this isolate, or if possibly the patient wasn't as compliant in taking their drug as once thought. Because if the patient is still positive after 4 months, you should really, you need to reculture the patient, and you should really be concerned about possible drug resistance. Tuberculosis, of course, is a classic primary disease, is a slowly progressive pulmonary infection with cough, weight loss, and low-grade fever. The presentation can vary, of course, depending on the degree of immune suppression of the patient. You can have something like a Ghon's complex, where you have the primary lesion in lung and an associated lymph node. Or you could have a miliary TB, usually occurring in an immune suppressed patient, where you can have widespread dissemination. The infection will occur via the bloodstream. This occurs most often in AIDS, elderly, children, immunosuppression, and with some medications, particularly Remicade. You can also have secondary tuberculosis. This occurs mostly in adults as reactivation infection. This can be granulomatous inflammation that can be much more florid than in your primary disease. Usually will affect the upper lung lobes, and cavitation can occur quite commonly. TB is, of course, spread by respiratory droplet. So any patient that is suspicious for having TB must be placed in respiratory isolation precautions before you have eliminated the possibility of this infection. Pathology of MTB. Of course, the hallmark is in the infected tissue is a necrotizing granulomatous inflammation. But do remember that you can see non-necrotizing granulomas also. The granulomas are usually composed of epithelioid histiocytes surrounding a central necrotic zone. There can be a variable number of multinucleated giant cells and lymphocytes. TB and HIV and AIDS can be a little bit different. It's a common opportunistic infection affecting HIV/AIDS patients around the world. The trend is toward it being a multi-drug resistant isolate in these patients, at least resistant to INH and ribampin. With progressive decline of cell-mediated immunity due to lowering CD4 counts in these patients, it makes them a greater risk of extrapulmonary or miliary tuberculosis also. You can see granulomas with and without caseation. Outside the lung, you can see two major presentations of MTB. That would be scrofula and Pott's disease. Scrofula is the unilateral lymphadenitis, or a cervical lymph node infection, which is most often seen in the immunocompromised adult or child. Caseous necrosis is often present. Normally, a fine needle aspiration is used to obtain diagnostic specimens for culture in disease and to find the disease. MTB most often causes scrofula in adults, but it's of note to note that in children, you can see occasional MTB causing scrofula in children, but most likely it's going to be M. avium complex or another non-tuberculous mycobacteria. Pott's disease, of course, is TB infection of the spine. Usually it's secondary to a pulmonary infection that spreads from an ongoing pulmonary infection to the spine. It can manifest as a combination of osteomyelitis and arthritis that usually involves more than one vertebra. Mycobacterium bovis. This organism produces disease in warm-blooded animals and cattle. It's spread to humans by inhalation of animal products or raw milk ingestion. Disease states in humans are similar to that caused by TB. Can't help but bring up some of the old biochemical reactions that have been over the years very useful in separating M. bovis from MTB. You can see that unlike TB, M. bovis is negative on the nitrate test. It will not grow in the chemical T2H, which for a long time was used to separate M. bovis from MTB. It does not produce the pyrazinamidase enzyme, and it is resistant to pyrazinamide when doing susceptibility testing. M. bovis, BCG, of course, is the attenuated strain of M. bovis. This is the strain used for TB vaccination around the world that have a high prevalence of TB. It is also used as installation into bladders to treat bladder cancer. And this seems to be the primary way that we see M. bovis in infections, is sometimes the BCG installation can actually bloom and cause infection in the bladder in these cancer patients. Mycobacterium ulcerans. This is also known as Buruli ulcer if you're in the African continent, or better known as Barnsdale ulcer in Australia. This infection is endemic in tropical areas, usually areas with limited medical care. It starts with a mild skin trauma forming a nodule from the exposure to contaminated stagnant waters with this organism. But it can lead to a very progressive and destructive ulcer and can lead to disfigurement and disabling. You can see the picture on the upper left-hand side. The peak age group is usually children 5 to 15 years of age. This is due to the production of mycolactones, which is a cell cytotoxin. If you're doing cultures to look for this agent, you need to remember that its optimum growth temperature is 30 degrees centigrade. It does not grow well at all at 37. So this is unusual. And it's also something, in fact, to remember about AFB skin lesions and AFB organisms from skin sites in general. Skin lesions should all be grown at 30 degrees and 37 degrees because most of the organisms that cause infection in the skin grow best at 30 degrees. This organism can be difficult to grow, and molecular techniques are the methods of choice. Mycobacterium kansasii. This is a mycobacteria that grows well at 37 degrees in around 10 to 20 days. It's a photochromogen, producing a very bright yellow pigment when exposed to light. Old tests would be niacin test negative, nitrate positive. Tween 80 is positive. It tests for the presence of the lipase enzyme, and Mycobacterium kansasii is one of the few species that has this enzyme. It's also positive in a 68-degree catalase test. More likely, we're going to do MALDI-TOF or use DNA-RNA probe for identification. One of the characteristics that's very interesting for this organism is what it looks like on an AFB stain. Notice that the AFB are quite large, and if you look around enough in a field of M. kansasii, you might be able to see one that's in the shape of a shepherd's crook. This is classic for M. kansasii. That is shown in the picture on the upper right-hand side. The clinical disease for M. kansasii mimics the pulmonary disease of MTB, but it is not going to disseminate out of the lung. It stays confined to a pulmonary disease. The disease is acquired from contaminated tap water. The predisposition is usually for someone that has lung disease already, such as COPD or pneumoconiosis. It's also more likely that you would see it in an immune-suppressed, alcohol abuse patient or someone with HIV. It will produce granulomatous inflammation in the lung. Mycobacterium marinum is also a photochromogen. It grows at optimal temperatures of 30 degrees because it causes skin infection. It does not grow at 37 very well and will grow in 5 to 14 days. The normal inhabitant of this organism is fresh and salt water. Because of that, infection is associated with skin trauma that occurs in an accident in the water usually, such as scraping in a swimming pool, cleaning a fish tank with bare arms or hands, surfing in the ocean and scraping up against rocks, or punctures from fish fins. The disease will start off as a tender red or blue-red subcutaneous nodule at the site of trauma, and then that will develop after 2 to 3 weeks. If it's treated at that point, that could be the end. You would do a biopsy from that skin nodule and do culture and histopathology. But if it is not treated at that point in time, it can classically spread up the arm along the lymphatic channels, as you can see on the picture on the bottom right-hand side. This is the classic spread up the lymphatic channel with serious nodules progressing. This is also a very classic look to some other infections as well, such as sporotrichosis, nocardiosis, and the rapid-growing mycobacteria. So it's very important not just to do histopathology, but to do culture to get the right organism, also to take a good history to know what might have caused these lesions. Mycobacterium schulgii, this is the one that I had mentioned previous, has a very unusual light test reaction. This used to mean a lot to us when we were using biochemicals, that it was a scotochromogen at 37 and a photochromogen at 25. It's the only AFB species that has a different light test based on temperature of incubation. It grows well at 37 degrees. It's a rare cause of pulmonary disease in adults, mostly associated with alcoholic abuse patients, patients who smoke, COPD, AIDS, and the immune suppressed. The pulmonary symptoms will be very much like TB. Mycobacterium xenopi. It's a scotochromogen and is known as a thermophilic AFB. This one will grow very well at 42 degrees centigrade. Because of this, it is a primary nuisance in hot water systems, and this is usually the way that most people are infected. Hot water systems that are not filtered or cleansed properly. It will grow in about 14 to 28 days at both 37 and 42 degrees. The most classic thing about M. xenopi is the egg nest colony that is produced on solid media. Take a look at that picture on the right-hand side, the upper one, and you can see little egg nest looking colonies on the plate. Truly classic. It's a rare cause of pulmonary disease, has a classic pulmonary infection like TB, occurs in patients with pre-existing lung disease such as chronic obstructive pulmonary disease or bronchiectasis and HIV/AIDS. Mycobacterium avium complex. This complex includes 8 species of organisms found in the environment and in animals. It is non-photochromogens. All species are biochemically and genetically very similar, so it's been very useful to have such techniques as MALDI-TOF and 16S RNA DNA sequencing to be able to identify these organisms. The most common species are M. avium and M. intracellulare. They grow at 37 degrees in 7 to 21 days as smooth, creamy colonies and buff-colored. As previously said, the rods are short, they do not bead, and they're in irregular clumps. They're inert in biochemical reactions, so we must use molecular DNA or RNA hybridization probes. That will get us to the complex, but for full speciation, MALDI-TOF, and 16S sequencing. The disease in somewhat normal hosts for the M. avium complex is adults mostly have chronic pulmonary disease. It can be fibrocavitary or nodular bronchiectasis presentation. The most common thing is for the adult to have a chronic cough syndrome. This is particularly common in the elderly, and usually these people have had prior lung damage, COPD, and a lot of them are smokers. Children will most likely have a scrofula type infection with the M. avium complex, with chronic granulomatous inflammation and lymph node involvement. One of the other really unique species of the M. avium complex has been M. chimera. This is an environmental and nosocomial organism that got a lot of press when it was reported as a contaminant in a heater-cooler units that were manufactured and used in cardiac surgery. The units were contaminated upon manufacturing, and when surgical centers used water and aerosolized water through these cooling units in their surgical procedures, they were found that they were spraying water that was contaminated with M. chimera. So this airborne transmission of this organism over an open surgical field cause post-surgical infections. So this is one very claim to fame for M. chimera. M. avium complex, also known as MAC and MAI, certainly has caused problems over the years with HIV/AIDS. It has been one of the most common opportunistic infections in AIDS. It's a little bit different type of infections in these patients. It's non-specific, low-grade fever with weakness, weight loss, kind of a picture of fever of unknown origin more than a pulmonary infection. The diagnosis is, of course, isolation of MAC from respiratory or other specimen sites, such as blood or bone marrow in disseminated infection. You can also see abdominal pain and diarrhea in these patients, and it can develop malabsorption. We can actually see positive AFB smears in stools and can culture MAC from stool specimens in these patients. In tissue examination, we will usually see non-necrotizing granulomas. There can be a very high organism load with MAC in tissue of these immune-suppressed patients. And of course, the AFB will be small, not beaded, and in clumps. M. avium in a Kenyan-type stain. The one on the upper left is of a lymph node. You can see how it can just be packed with AFB. You can also see granulomatous inflammation, but lower left on an H&E stain. And on the right-hand side, it shows how these organisms can appear in the bowel. You can see the lamina propria expanded from predominantly a lymphohistocytic infiltration. And if you were to do an AFB stain, you would see the organism. The rapid grower Mycobacteria species. These will grow in less than or equal to 7 days. They are very low virulence organisms and found in the environment as contaminants. There's 20 species, but the most common that we see in culture are M. fortuitum, M. chelonii, and M. abscessus. M. fortuitum is usually seen in skin and surgical wound infections when they've not been taken care of post-surgery, and also catheter sites. M. chelonii is skin infections in mostly immune-suppressed, as well as catheter sites. M. abscessus can cause chronic lung infection, which the other two most normally do not, but also skin infection in the immune-suppressed. All 3 species will be aerosulfatase positive, and if we go back in time and use biochemicals, M. fortuitum will be nitrate reduction positive, iron uptake positive. M. chelonii and abscessus are nitrate negative. It is best that you use MALDI-TOF or sequencing for the identification of the rapid growers. The antibiotic therapy is assisted by directed susceptibility tests. You can have variable susceptibility patterns within the groups of the organisms, but clarithromycin is usually a primary therapy. Over time, we've wanted to have rapid help for detection of resistance for these organisms. So there's actually molecular genetic testing that can assist with clarithromycin resistance and provide very rapid information for how you should direct your susceptibility, your therapy rather, for the treatment of rapid growing mycobacteria. Some of the unusual miscellaneous species of mycobacteria. We need to certainly mention Mycobacterium gordoni. This is a scotochromogen, and it's not important necessarily for causing infection because it rarely does. But this one is commonly found in tap water, and it's a very common contaminant that we can see in our AFB cultures, particularly if you're not very careful in your use of certain kinds of waters and things that you use to make your biochemicals and such, or your chemical solutions. So you need to make sure that you can identify M. gordoni rapidly and separate it from the pathogenic mycobacteria so that the patient is not unnecessarily treated for an infection that they do not have. This is a very important Mycobacteria species, Haemophilum. This is a fastidious, slow-growing AFB requiring the addition of hemoglobin or hemin to the culture media for growth. This organism will not grow on your standard Lowenstein-Jensen media, Middlebrook, or in an automated system, Middlebrook 12B media. You need to be on the thought process, on the outlook for this. And so when you get skin lesions into your laboratory, you should always put them on a media that contains hemin supplement, such as a chocolate agar. They grow best at 30 degrees centigrade because they are skin lesions. The disease that Haemophilin produces is a very painful subcutaneous nodule and ulcers, primarily in patients with AIDS or immune suppressed. It can also cause lymphadenitis in children. Mycobacterium leprae. This is the cause of leprosy or Hansen's disease. This affects the skin, peripheral nervous system, and mucous membranes. The clinical signs and symptoms can help you aid in the diagnosis of this infection. Usually there's a peripheral neuropathy with nerve thickening, numbness in earlobes or nose, and loss of the eyebrows. Infection is by person-to-person spread via inhalation of infectious droplets. It's curable with early diagnosis and appropriate therapy, which is usually dapsone with rifampin or clofazimine. It can be endemic in India, Brazil, and Indonesia, and there's primarily two types of leprosy, Lepromatous and tuberculoid. Lepromatous causes severe disfiguring lesions with large numbers of AFB. Tuberculoid is less severe with fewer lesions. M. leprae is non-culturable on laboratory media, so PCR must be performed on tissue for definitive diagnosis, and of course the public health department will help you out with such a diagnosis. The armadillo is a natural reservoir for M. leprae. Lepromatous leprae is also known as multibacillary leprosy. As I said, loss of eyebrow and deformity of the face. The AFB will be abundant in the tissue, and they will appear in a cigar packet type arrangement, and there will be numerous AFB. Also in the skin biopsy, you'll be able to see AFB in the nerve fibers. On the right-hand side is the tuberculoid leprosy or possibacillary leprosy. You can see that the lesions are far less debilitating, they're less deformity to the tissues, and you can also see that there's far less organisms in the tissue upon examination. Well, that is my last slide for this lecture. I would be happy to entertain any questions that you might have concerning the review of Mycobacteria. And I thank you for listening, and see you again soon in another topic. Thank you very much.
Very elaborate discussion on mycobacteriology and so many different aspects of it. So there were a lot of viewers online, and I have one question that I see. This is regarding rapid growing mycobacteria. So do they respond to conventional anti-tuberculosis drugs, or they need different therapy?
The rapid growing mycobacteria are really a little bit separate beast. There's even been some new taxonomic rearrangement to move them out of the genus of Mycobacteria into kind of their own kind of special mycobacterial-like genus. And because of that, and because their cell wall is a little bit different and such, they do not respond to your regular primary drugs for TB. So that's why it would be very important to identify them and know what you're dealing with.
Right. And is there another question along with that? So is there any specific culture requirement on that for rapid growing mycobacteria? I think you mentioned that, right?
Well, they grow very well at 37 degrees. And the wild thing about the rapid growing mycobacteria, they do grow rapidly. You know, they can grow, in less than 7 days, but oftentimes they can start appearing as very small colonies in 2 to 3 days on just regular blood agar, chocolate agar, in your regular bacteriology laboratory. So I would say we probably pick up as many rapid growing mycobacteria from just a lesion culture in bacteriology as we do in our AFB laboratory. So it does not require any special media. It grows very well on regular bacteriology media, as well as the media that we use in our AFB laboratories.
Thank you. There is another question regarding laboratory detection of mycobacteria. So which technique do you use more commonly for routine detection? Is it the carbofluxion method or you do the aramine-rhodamin method?
That's a very good question. We use the aramine-rhodamin for the screening of all of our patient specimens. It is we believe, a more sensitive stain due to the fluorescence. But whenever we have a positive stain on fluorescence by aramine-rhodamin, we will go back and make another stain using a carbofluxion Kenyon method for permanent, to have a permanent slide that we don't have to view under a fluorescence microscope. Also, sometimes you can see the morphology of the AFB, the beading, and just general morphology better on the Kenyon stain. So we primarily screen all with aramine-rhodamin, and then we would confirm and look at the morphology on a carbofluxion-based Kenyon stain.
Right, thank you. And the next question is somewhat related. So what's the exact difference between Kenyon stain and Gill-Nielsen stain? Is it same or it's different?
It's same but different. That's a very good way to put it. I have been in microbiology for many years, and when I first started in microbiology, we did the true Gill-Nielsen. As I said in my lecture, Gill-Nielsen relies on heat to drive the stain into the lipid-laden AFB. When you do a Gill-Nielsen, you actually put the slides onto a staining rack, put the carbofluxion onto the slide, and then you run a Bunsen burner or some heat source underneath the slide to break down the lipid to allow the stain into the organism. That was found to probably not be particularly safe over the years, and so they developed a cold Kenyon stain where instead of using heat, they use its phenol to break down the lipid in the cell wall. So you can just put the stain onto the organism or use automated stainers with the Kenyon method. So most laboratories these days would use the Kenyon stain, not the old Gill-Nielsen. But ZN has just kept in our memories, I think, forever. And so a lot of people will incorrectly use ZN, although they're actually performing a Kenyon.
That's interesting. So actually, it reminds me that probably there is another version of the stain which is known as fight stain, if I remember correctly. Do you have any comment on that?
I'm a PhD in microbiologist, not a pathologist, but I believe the fight stain is mostly used in tissue. And I have never used it very often, but it is capable of staining AFB in tissue. But I would not be the one to perform that. That would be performed in a histopathology laboratory.
Oh, that's interesting. Right. So, I would be interested to know from the histolab if they still do, what is the exact method they do for AFB stain. So whether it is a modified Gill-Nielsen or it's a Kenyon stain, that would be good to know.
Yeah, and I think a lot of the pathology departments probably also make use of the aramine-rhodamin fluorescent staining at times as well.
Right. So, but that aramine-rhodamin can also be done on the tissue sections, isn't it? Or
yes, it can.
Right. But for that, will it have to be processed separately because it will probably not work on formalin-fixed tissue, right?
I think that would be correct. However, I have to admit, I have never personally performed an aramine-rhodamin on a tissue. Right. I'm in the microbiology laboratory. Yeah.
Right. No. Yeah. I think. Here is another question regarding photochromogens. So this is about Mycobacterium sulgi. So is there something specific that it becomes photochromogen only at 25 degrees centigrade?
Oh, I guess I should have done my homework better. I can't really, I can't remember, and I cannot tell you exactly why it has a different temperature and different reaction in the light test. I just know historically, and when I first started in microbiology, that was a very, very important test for us to be able to identify that unusual species. And it sounds like this is just total trivia, but this was totally used as a diagnostic test. So that's why I thought it was kind of interesting to bring it up. And it's something that's always been associated with that organism. But I'm sorry, I don't know the exact mechanism of why it has different temperatures.
Oh, no, no, no. The question is not about why. Just someone was trying to confirm it, that is it true that it becomes a photochromosome at 25 degrees? No, no. Yeah, no, I think that's fine.
Yes, sorry, yeah, scoto at one and photo at the other. Yes, and I know that sounds like who would ever do that, but in the older times when we did not have the sophisticated methods of today, we used to use that Runyon classification system as the beginning of organism identification, and that would drive us to then use certain flow charts for the correct biochemicals. So we used to do things like different temperatures, light tests. It sounds crazy now, but that was the norm.
Right. So for now, it's like that Runyon classification is obsolete. Is that correct? I don't know. I'm just asking you.
Yeah, I would say that it is mostly obsolete, but most people would go directly from your 12B media in the automated BACTEC system using DNA, RNA hybridization probes for identification. And then if things did not identify from those probes, you would grow it onto solid media, of course, and that would take about 10 days at least. And then you would perform either a MALDI-TOF analysis or sequencing for the speciation of your mycobacteria. We really bypass biochemical testing altogether these days.
Right, right. But I think still as students in clinical pathology or microbiology, so we all need to remember those classifications still, right?
Yeah, I would agree with you. I think that it's very important to remember how we evolved. And it's not always been just, oh, take everything to MALDI. That's not much to learn about the organisms, is it, if everything just goes to MALDI? And so I think the mycobacteria truly have some unique characteristics. And so I thought it was important to bring those out in this lecture.
Thank you. One last question is about cord factor. So you talked about cord factor. How specific is it for M. tuberculosis?
Cord factor, in the extent that I talked about, is very specific to MTB. You're not going to get those ropes of organisms in broth or true multi-organisms sticking together in an AFB smear on any organism except for Mycobacterium tuberculosis. I'm not saying that occasionally a couple organisms won't be on top of each other or something, and M. Consaceae might be near each other or such, but the true sticking together and roping of the organism due to cord factor is specific for MTB.
Thank you. Thank you so much, Dr. Morgan, for your excellent talk on mycobacteriology and also answering all those questions in explaining and making us understand the topic better. So we really appreciate it. And you would be happy to know that we had lot of viewers from across the world, even though the time is like different. So they all defied time zones. I could see viewers from Nicaragua, Hungary, Tanzania, to name a few. Thank you again. And for the viewers, thanks for all your support. Our next lecture is coming up on Tuesday. That would be your November 10th. Yeah, sorry, that's actually on November 6th. Sorry about that. So it's a lung pathology lecture. So Dr. Thomas Kobe and Dr. Kevin Leslie will continue their lung pathology lecture series, and that would be the third lecture in their non-neoplastic lung pathology. And the topic will be diffuse lung disease with granulomatous features. And once again, it's on November 6th, 8 a.m. Eastern time. And please follow our lectures and stay updated by subscribing to our YouTube channel and as well as following the Facebook page. And of course, please don't forget to subscribe to our newsletter. So thank you so much again, Dr. Morgan. Thanks for joining us today.
Thank you.
Thank you.